So today we're doing medical ethics. We'll just go around and introduce everyone again. So I'm Edward.
I'm Hisham.
I'm Anne.
And I'm Amel.
Cool. And so with medical ethics, the main thing is the 4 pillars of medical ethics. So we've all got one pillar each that we're going to do. So I'm doing autonomy. Hisham, which one are you doing?
Justice.
Anne?
I'm doing Non-Maleficence.
And Hisham?
I'm doing
Anne's on.
yeah, Beneficence.
Okay, cool. So who wants to start? Which way should we go? Do you want to just go in the order that we choose?
Yeah, I can go if you want.
Okay, I'm going to start. Yeah.
To like introduce each pillar, and then after we've like briefly spoken about each pillar, we'll go back and like look at case studies and like how they overlap and everything. So
okay, so we introduce each pillar first and talk a little about. So each of us talks a little about each pillar, and then we do the case studies afterwards at the end.
Yeah.
Cool. Okay.
Okay, so beneficence is the duty to promote the patient's best interests at your own heart, and making sure that all treatment is based around them and what's best for them, both medically wise, but also to do with their own individual circumstances. So what's best for like them, considering their own beliefs and the family, and also just them as a person, like what they want. So it ties in a lot into the Hippocratic Oath. And obviously a major thing about that is basically doing everything you can to help the patient and trying to pursue that for the patient. And so the Hippocratic Oath is basically an oath that was created back in during the Greek times, and it was when the medical profession didn't have the level of trust with the public as they do now. So it was very important then, and it still is important now. And it's just about making sure that medical professionals make sure that they always put the patient first, and that's beneficence, basically.
Cool.
Yeah.
And do you want to go next?
Yeah, I can go next. So my pillar was Non-Maleficence, and in a way it's pretty similar to Beneficence, but whereas Beneficence is like doing what's best for the patient, Non-Maleficence is not doing harm to the patient. And it's less situational, more of a constant, because with Beneficence you would like look at a particular situation and think, okay, what is the best possible like treatment for this patient? But with Non-Maleficence, it's just a constant throughout. Like you must not harm the patient in any way. So if, for example, you had like a range of treatments, with a Beneficence approach, you would like rank all the options and be like, hey, this is the best one, this is the worst one. But from a Non-Maleficence like standpoint, I guess, you would just completely disregard the options that do more harm than good to the patient.
Yeah.
So that's basically Non-Maleficence and how it's like different.
Cool. Hisham?
So justice is all about fairness and equality, and a lot of the major things is about everyone having an equal share of like the health service. Everyone's entitled to the same treatment and that kind of stuff. But there are some like arguments and grey areas where things like, of course, cancer patients, like they really need their treatment, and like obviously you're going to invest more into them than other patients because their treatment is really important. And there's things that the NHS has done, such as like the maximum waiting time for like someone who needs like the oncology department is like 18 weeks, which is a lot shorter than some of the other waiting times because they are quite in priority.
Okay, cool. My pillar was autonomy, which is it'd be quite controversial. It's basically you have to get consent for everything you do during healthcare, and if you don't, that goes against the ethics. So even if something is going to improve the life of this patient, at the end of the day, if the patient doesn't want it, you can't do it. That's just not allowed. So that's what autonomy is. So autonomy ties into the law quite a bit as well, and one thing that's quite important is, so if you're under 16 in the UK, you can only make your own healthcare decisions if you are considered Gillick competent, and that's basically where you take a test called the Gillick test, and basically, if you do well, that means that you can make your own medical decisions. If not, you need someone else to make them for you. That's about it. And then the plan now is we're going to go through some case studies around the different pillars and see where the overlaps are and see if we can come to some conclusions as well. So should we get our case studies up, and then give me 1 second and we'll give it a go. Should I start with a case study?
Sure.
Yeah.
Okay. Let's give it a go. So, a 74-year-old man with multiple chronic medical problems was hospitalized for respiratory distress. He experienced recurrent aspiration and required frequent suctioning and endotracheal intubation on several occasions. The patient was deemed competent and steadfastly refused feeding tube placement. The patient demanded that he be allowed to eat a normal diet despite being told it could lead to his death. The patient wanted to go home, but there was no one there to care for him. Additionally, neither a nursing home nor hospice would accept him in his present condition. So what do you think you could do with this case if it was happening to you? If you were in the position of the physician?
See, so this is where overlap occurs, because obviously it would be important to take in the patient autonomy of wanting to eat normal food, but that would contrast with the non-maleficence because he's physically incapable of eating normal food. So by allowing him to attempt to would do more harm to the patient than good, which is why it's hard to narrow down a correct answer for that.
Yeah, and that ties in with Amel's pillar as well about choosing the best option for the patient as well. Yeah.
Yeah, I mean, obviously the autonomy has to be based on actual facts and science. It can't be based on untrue beliefs and stuff. So obviously you first need to make sure that they really understand what the consequence would be, and they need to understand all the facts. However, if they're still saying no of that, you can't, as much as you want to help the patient, you can't force a treatment upon them. But then obviously the bit where no care home would take them in, that's obviously really bad. So you have to try and find a middle ground somewhere. I've also got a possible one. So, do not resuscitate order. I think that's actually a clinical decision. It's not based on the patient's autonomy. So whatever the patient decides, if the clinician has said otherwise, that a DNAR will be issued, then that's legally binding, no matter the patient's wishes. So we could go into that. But let me just check that first.
Yeah, let me read about the conclusion for the case study.
Yeah, was there a conclusion to yours before we got
into
it?
Yeah.
We could also do like euthanasia or something.
Yeah, no, I was looking at euthanasia as well because that conflicts quite a lot of them.
Okay,
I think it might have overlap with all of them actually. Oh yeah, go on, sorry.
So this is the conclusion to that case, sort of. So this was off a website I found. So this case poses many issues faced in hospital daily. It's hard to go against what the patient was requesting, even if they're requesting something that is in turn hurting their health. So again, tying into those two pillars. So this could possibly lead to the doctors to perform acts of beneficence where they will have to disrespect the patient's decision on treatment in order to save his life and prevent further harm. A doctor should follow beneficent acts and perform whatever action is necessary to save the patient's life. So I think the key in this one is what Amal was saying about making sure they understand the consequences of what's happening.
Yeah.
Because they need to, obviously the case said they were competent, but that doesn't mean that they necessarily have been explained all the consequences of what could happen. So they need to understand, maybe be told by the doctor or whoever's taking care of them, the consequences of what's going to happen if they eat their normal diet without having a feeding tube in them, which is, according to this case study, probably death. So they should definitely understand that. And then if they still refuse, I guess you can't do anything. But yeah, Am, were you going to say something?
Yeah, so I think that links in elsewhere as well. So I think autonomy, for it to be, obviously it's always to be respected, but for it to be like the final decision, if you will, it needs to be based on proper facts. And for some areas of medicine, like for example, in plastic surgery, when patients want to change the aspect of themselves to look better, even though it's not the best medical thing for them to do, often their decision to do that is based on untrue facts based on the internet and society. And therefore that also links in with that saying, so the autonomy is based on untrue facts, so they need to take that into consideration as well.
Yeah. And going back to what Edward said about the patient being competent, a person could be deemed competent when they have like a level head and everything. When you're making a serious decision like that, it's hard to know how you'd react with like emotional turmoil as well. So that's why autonomy, while it's very important, it can be difficult to judge how competent a person actually is to make decisions about their medical well-being. which links back to the Gillick test, I think it's called.
Yeah, because in the moment it's different to when you're sitting in like doing a test or anything. You know, in the moment it's so different because you're being told, you know, the life or death situation. So yeah. Do you want to do another case study?
Should we do Charlie Gard?
Yeah.
An interesting case to do with justice is Charlie Gard, because there's this thing that they do in the NHS. It's all about quality assured life years, and it's to do with this idea that for a year of perfect health, the cost is around about 20,000. Anything like 20,000 to 30,000 or above is like harder to get past the NHS. But under that threshold, it's deemed like suitable. But there's this case of Charlie Gard, which is this newborn baby, and he was born with this really rare mitochondrial disease, which left him with a lot of issues with his I'm pretty sure he was like blind and deaf and stuff like that. But the quality assured life years for his treatment was like around about £150,000, which is well above this £20,000 like threshold. So the thing with justice is, do you spend this vast amount of sum on saving one life where you could do a lot of little treatment with that amount of money? You could even just like give out drugs like statins, which should prevent a lot of heart attacks and things like that. So that is like the problem with Charlie Gard's case. And then of course it ties with like non-maleficence and benevolence, because you're trying to do what's best for this patient, you're trying to save his life and that kind of things. But also he is in a lot of pain, and that is what like the courts decided, that putting him through treatment is also not worth the damage you're going to do to him, because he's already suffering, and if you're putting him through more, is it fair for that patient?
I think so. In his case, obviously his parents and at that time I think it's like Great Ormond Street Hospital, they disagreed on what course he should take. So I think his parents wanted him to go experimental like therapy or treatment in the US. Well, it's known. I think Great Ormond Street Hospital, they said no, and they believe it is in Charlie Gard's best interest to obviously no longer give treatment. And obviously there was it's a took the interest of the whole world about it. And obviously Beneficence. So in the medical team's personal opinion, not personal but professional opinion, they thought it was wise to not carry on and not give him that experimental treatment, because he's in pain. His quality of life after will not be good, and therefore it was in his best interest to not do it. Well, obviously, the patient's autonomy, he's a baby, but his parents wanted him to undergo this, and then area as well.
It's almost an overlap of all four kind of medical pillars, and they're all kind of I mean, I guess that's why it was such a big case as well. I mean, because it had a huge thing in all the news and everything, and everyone kind of know about it. So yeah, probably why. I've got the actual Supreme Court ruling. Give me 1 second now. See if I can find
Supreme Court.
Yeah, so it was taken to court in the UK, the Supreme Court, to see what would happen. And the official PDF is like 5 pages long. Oh my goodness. Okay.
I've got a quick summary here.
Yeah, I do that. Yeah, because I'm not reading that entirely.
So the parents brought in an American doctor who's at the time a very he's still maybe, I'm not really sure, but he's a respected professor in neurology, and he said that his treatment would give a significant improvement, and basically he offered this thing called nucleoside therapy, and this reduced the amount of time on a ventilator. But obviously the thing is that this American doctor didn't examine Charlie, and they weren't there, and they didn't oversee Charlie's treatment at the time. So it's quite hard for him to have a fully comprehensive view of what to do with Charlie.
So Charlie's parents disagreed with the hospital and did not want his life support to be withdrawn. The doctors applied to the High Court for judges to decide Charlie's future. And in April, the High Court agreed with the Great Ormond Street doctors to discontinue his life support. But then appealed against the decision, but the courts then ruled the original decision should stand with it, and that it would be in Charlie's best interest to die with dignity. So I think he's dead.
Yeah.
Mm.
Obviously, it's hard because it's their child, but at the same time,
Yeah, like of course it's difficult if you're a parent put in that situation, like all the medical professionals telling you there's nothing you can do. Of course you're gonna want to try find some sort of solution for your child. So it makes sense what they did. It's just
Oh, this is interesting.
Yeah.
Okay, so you're talking about that American professor you're talking about.
yeah.
So I was just looking at the news. So after examining Charlie, Professor Hirano, who I think is the US professor, said it was now too late to give Charlie the therapy. After seeing an MRI scan, he said it was too late. So even if they had managed to go to the US, I don't think they would have made any progress with it. So that might have.
So I think they did ECG as well, and like that found and didn't that like help make their decision? Yeah, because obviously, as you were saying, as like the family, you want the best for your relative, and it's really hard in that sense to agree with doctors, because the doctors, although they give a compassionate view, they're very not alienated, but they don't have any personal
connection with the patient.
and therefore it's
exactly.
a lot easier, if that makes sense. Although it's still really hard.
It's obviously a difficult decision, but when you don't have a personal stake in it.
Yeah. But like, I just want to bring this out. Maybe it's a little bit too deep, but should medical treatment be based on personal reasons, such as like they're still a person and the parents or the relatives want the best for them, or should it be based on a more clinical aspect where it's no use, they're going to live in pain, and it's not within their interests? So yeah,
I suppose that links back to what Hushan was saying earlier as well, because from a personal level, of course they're all people. You want to save every single patient. You want to provide each patient with the best possible treatment. But in a case where the cost of treating this one patient is so much higher than the cost of treating several others, you sometimes have to make a call that's
agreed. Also, with his particular disease, I feel like all he would have known was pain. Like it's like a really bad neurological disease, and he was getting like muscle weakness and everything. Like we all do, we all know biology, we all know how important mitochondria are, and he had a serious issue with them. So like with progressive brain damage and muscle failure, I think doctors had to have like a very hard decision about what to do in this case.
So to do with this, if anyone else wants to talk about like the Charlie Gard case, so in like the hard decisions bit, we can link to maybe battlefield treatment as well. So if you've one person who's needing a blood transfusion, but they'll take all the blood up, when you could save one person but save 5 other people, we could do that maybe.
Looking into what you said earlier, Amal, about quality of life, it's also why the topic of euthanasia is why it's so ethically charged, I suppose. Because it sort of links into all 4 pillars, really. Because the idea of like assisting death, I suppose, would go against pretty much everything what non-maleficence is, because you don't want to harm the patient, and obviously death is harming the patient. But at the same time, if the quality of life of the patient isn't going to be good, would it be in the best interest of the healthcare service to preserve that life, especially if the patient themselves wants to be euthanized?
It's very hard, because obviously here you're not allowed to, so often they have to go to maybe Switzerland, I think, Geneva especially.
I'm just having a look. So Switzerland, Netherlands, Belgium, Luxembourg, Canada, Colombia, Australia, and the US, in certain states as well. And there's a few others as well, but still not the UK.
So yeah, obviously, because you can go to another country and get it, it's not regulated. But yeah, obviously it goes hugely against the Hippocratic Oath, which is basically there to say you can't do any harm. You have to put the patient in the front. You have to try and do everything you can to help them. and like make sure they don't die. So it's literally the opposite.
Yeah.
But then also you have to bring up their personal choice, and when they're in really great pain or just emotionally they don't want to go on anymore, you have to also take that into consideration. It's really hard.
Yeah, very
As
much to do with autonomy as well. Yeah.
Great areas.
Yeah.
There's some good stats on like inequalities and like race and stuff in the NHS.
Yeah, go for it. Yeah.
There are some interesting stats about the NHS. There's this really interesting one about death during childbirth, and we have the stat that Black women are 5 times more likely to die than white women. And like there is a similar trend with like Asian women being 2 times more likely and mixed ethnicities being 3 times more likely. And there are like some studies being made and investigations by the NHS, but this is like 5 times. That's a huge stat, and it just shows us how like there still isn't complete justice and equality. And then it makes us like have to look into like our society and things like that and what could be causing these issues.
Yeah, we saw that with COVID as well. I mean, I'm sure you've seen that they did like I think a TV show, I can't remember which actor it was, in looking into why the Black ethnic minority groups are dying so much more than white, like British Caucasian. And they're still looking into it, but it's evidence that despite obviously we are making quite big leaps in within the past a few decades racially, there's still quite a long way to go.
I think I watched a documentary in school actually.
I remember watching a bit of it.
Yeah. But yeah, definitely. Obviously, it's still not gonna. It's still there. There's still traces of it, and I think, obviously, you try to do everything you can to make that go away and make that to be equality. But it's still there. It's still a problem. So we need to address that. It's interesting how you said for Black women it's 5 times more likely, because that's not even like a minute or a small difference. That's a lot.
No, that's huge.
Yeah, that's huge.
That's huge. Yeah.
And I think that gives us a reality check. Really, like it's massive. Yeah.
Going off on a tangent a bit. I think I read somewhere that women are a lot more unlikely to have like a successful CPR done to them, mostly because of the way that CPR is taught, because most of the dummies are male, so people aren't equipped to deal with female bodies, which isn't really strictly relevant to what we're saying, but I just thought it was interesting to mention.
I mean, it's kind of into to do with justice a bit about the equality of patients and things, and I mean, in that last minute scenario, if someone doesn't know how to do it on someone different person type of body, then that's definitely going to cause some problems. Yeah.
CPR though, it's very, it's a very, how do I say this? Although it's obviously great and it's a good tool to help save someone's life, it's also sometimes quite unsuccessful in many attempts. So and it obviously depends on where they are, whether there's like defibrillators around them and such. But because always at school or when you do like any like first aid training, it's all the male dummies when you try to
So I don't have a specific case study, but I have an example of a scenario that links into like non-maleficence. And it's on the medic portal. I'll just read it out. So a 52-year-old man collapses in the street complaining of severe acute pain in his right abdomen. A surgeon happens to be passing and examines the man, suspecting that he is on the brink of rupturing his appendix. The surgeon decides the best course of action is to remove the appendix in situ using his penknife. Now, from like first reading, it does seem like, okay, yeah, maybe that's the best thing to do, just like remove the appendix to like preserve the patient's life. However, you have to consider the fact that it's just in the middle of the street, not going to be sterile conditions. The surgeon's just acting on his own. So while a more beneficent solution would be to remove the appendix where you are, you would probably end up doing more harm than good to the patient, especially if it's just done with a penknife.
Agreed.
So that would be an example where non-maleficence overlaps quite heavily with beneficence, because you it's a difficult decision to make, but the best thing to do would be to try to get to the patient to a hospital rather than risking the patient's safety in the street there and then.
Yeah. I think if you're in that situation, I'm not sure, because I know there's obviously some legal cases but which regard that, as you said, Anne, and I'm not sure if it's like illegal or legal to actually do that if you're asked to like treat a patient who's in need. But I think the best way to do that is like maybe stabilize them in whatever way you can.
Yeah, exactly. Like performing an operation in the street would be like a really disproportionate solution.
It's
very extreme.
Yeah.
I mean, and also if they're a trained surgeon, they probably know how to stabilize someone until the ambulance gets there.
Exactly. Yeah.
And then because without their team, a surgeon isn't gonna. I mean, obviously they're very talented, but without their team,
it's a whole team.
It's not gonna end well. It is a whole team effort. They need the anaesthetists and all the nurses and everyone there. So without that, it's going to be a real struggle. Yeah.
I think to take into consideration, you also need to take into account the public's view of the medical profession. That's really important. So if you're like doing an issue with a penknife, obviously the view may not be great, and that can further affect how medical professionals treat patients in the future, and that could even do even more damage. So
So obviously again, that was like quite a drastic like scenario.
Extreme
but
scenario,
it was just to like show how like there are different overlaps between the different pillars more than anything.
Yeah. I also found a really cool fact. Sorry.
Can I, you know, when Edward was talking about the like disproportionate amount of BAME doctors dying because of COVID, there's this stat that 95% of the doctors that died during COVID were BAME background, which is really large.
And that is a huge 95% is it's almost all of them pretty much, which is insane to think about, really.
Makes you think like it has to be something more than just like socioeconomic factors and like age and stuff like that. Like we need to really look into that stuff.
Definitely.
I think it's sorry, I'm gonna go for it.
Yeah, so I think also, although it doesn't tie to any individual pillar, but into medical ethics overall, surprisingly, the UK hospitals don't have a medical like ethics team attached to the hospital. And that's really interesting, I think, because apparently in the US they do have a medical ethics team which are open 24 hours a day for surgeons and like GPs to talk to if they have like a case that they need maybe another opinion to. But yeah, I just found that really interesting that the UK hospitals don't have that.
We don't have it here,
obviously, for some cases, hospitals are often subjected to lawsuits, and that's very costly for the hospital, both in terms of money, also in like any other care they can provide for other people. Yeah, cool little fact.
Yeah, and I think with the lawsuits and things, it definitely ties into what Emma was saying about the public and the trust of medicine and things like that, which is so important. And that's sort of linked to, again, autonomy, because if there's a bad relationship between the healthcare system and the public, then you're going to have more and more people refusing treatment and more and more people using their autonomy and saying, I don't want this, which some of the time might not be in the best interest of the patient, going against beneficence, non-maleficence, that kind of thing.
We're also going to have people like holding back and maybe not telling the doctor everything that's wrong with them, which is not great, because like the relationship between a patient and doctor is very, very important, and you want to create a safe space wherein the patient feels they're able to tell you anything.
Yeah. But in terms of like, so I've got an example here where I think that's not the case. So I think when, so let's say eyesight, for example, when someone's, I think an old person's eyes are often like not as, they worsen over the years. And actually, if they get to a point where they can no longer see, doctors by law have to actually, I'm not sure if it is to get the case, they have to inform the DVLA, say that these people can't drive anymore, even if it is not within the patient's best interest, which I find quite, we should look into that safe space.
If they didn't, I think the idea behind that is obviously if they didn't inform the DVLA, then they could be posing a threat to other people on the road, basically.
It's also about wider society as a whole.
Talking about like trust, I think on the dentistry side of things, that's really important because a lot of patients, if they have like gum disease, if they have like bad oral hygiene, they're quite like embarrassed to talk to their dentist, but they shouldn't be. There has to be that level of trust and understanding, because a dentist needs to know how much you're cleaning your teeth, how many times you're brushing, what your diet is like, if they're going to give you an effective treatment, and they need to know all the facts and all the truth. If they don't have that, then the patient's going to suffer in the end.
Yeah, and I think, with the trust thing, it's through patient confidentiality as well. You can't go into the staff room and start talking about how bad your patient's diet is, or that they don't brush their teeth twice a day, or that kind of thing, because that's just going to absolutely ruin the reputation of both medical and also in dentistry, the same thing as well. Yeah,
agreed.
And even when you have to disclose information, it's only to like select organizations or people. So, for example, with the case of if they have like a virus or disease that could be, another person could catch it. You have to obviously report it, but you can't obviously report it and tell everyone.
Yeah,
you only have to tell the people that are needed to, like, it's a need to know basis, basically.
Yeah. All right, cool. Thank you for watching, guys. Next episode, we're going to be doing the history of the NHS and just a bit about the history of medicine in general. Peace out. Bye-bye.
Bye.
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 Oh,